If you have been taking amlodipine for more than 2 years, there is a very good chance something is happening inside your chest right now that your doctor has never directly explained to you. Not because they don't care, not because the medication is wrong, but because the conversation about what long-term amlodipine use quietly does to the heart valves in people over 60 is one that almost never happens in a 15-minute appointment. And by the time most seniors find out about it, the changes have already been building for months, maybe longer. I am Dr. Alex, and I have spent years working in emergency medicine, watching patients arrive with symptoms they had been dismissing for seasons. Fatigue they blamed on age, ankle swelling they thought was from sitting too long, a soft fluttering in the chest they decided wasn't worth mentioning. And almost every time when I pull up their medication list, there it is. Amlodipine, 5 milligrams, 10 milligrams. Taken every morning, sometimes for 5 years, sometimes for 10, trusted, familiar, and in ways that are not printed on the bottle, slowly changing the landscape of the heart valves that keep blood moving through the body in exactly the right direction. Now, I want to be clear before we go any further. Amlodipine, sold under the brand name Norvasc and also widely available as a generic, is a legitimate, effective medication for high blood pressure and certain types of chest pain. Millions of people take it. Many people need it. The goal of what I am about to share with you is not fear. It is understanding. Because when you understand what is actually happening inside your body after 60, you can have a completely different conversation with your doctor. A more informed one, a more protective one, one that may catch something early that would otherwise be caught late. So stay with me, because what I am going to walk you through today may be the most important cardiovascular conversation you have had in years. Let me start with Margaret. Margaret was 68 years old, a retired school teacher from rural Ohio, sharp as anyone you would ever meet, and proud of the fact that she had been managing her blood pressure without complaint for 6 years. She took her amlodipine every morning at 7, right after her oatmeal, without fail. Her readings were decent. Her cardiologist seemed satisfied. Life was manageable. But over the past year, something had shifted. Margaret noticed she was winded climbing her front porch steps. Not gasping, just winded. The way she never used to be. She mentioned it once to her doctor and was told it was probably deconditioning. She accepted that. She was 68 after all. Slowing down felt like something she was supposed to do gracefully. What Margaret did not know, and what nobody had ever explained to her, was that amlodipine, as a calcium channel blocker, works partly by relaxing the smooth muscle in the walls of blood vessels. That is exactly why it lowers blood pressure. But smooth muscle is not only in blood vessels, it is also in the tissue surrounding and supporting the aortic valve and the mitral valve, the two most important valves on the left side of the heart. And in some patients over 60, particularly those with any degree of pre-existing valve calcification or connective tissue changes that come with age, the long-term relaxation effect of amlodipine on that surrounding tissue can create a situation where the valve's mechanical environment changes in ways that accelerate the very stiffening and thickening that aging was already beginning. Margaret's follow-up echocardiogram, done almost by accident after an unrelated chest infection, revealed mild aortic valve thickening that her cardiologist described as, quote, consistent with early calcific changes, worth monitoring. He adjusted her treatment, added a different agent, ordered closer follow-up. She told me later that she wished someone had connected the dots for her 3 years earlier. I want to connect those dots for you now. The aortic valve sits at the exit of the left ventricle, the main pumping chamber of the heart. Every single time the heart beats, this valve opens to let oxygen-rich blood rush out into the aorta and from there to the entire body. Then it snaps shut to prevent that blood from falling back. In a healthy young heart, this valve is thin, flexible, and precise. In an aging heart, particularly in someone over 60, the valve's leaflets begin to accumulate calcium deposits, small ones at first, almost invisible on a standard scan. This process is called aortic valve sclerosis, and for a long time, doctors considered it a normal, benign finding of aging. But newer research has completely changed that thinking. Aortic valve sclerosis is now understood to be an active inflammatory and fibrotic process, not simply passive calcification. The valve is not just getting old. It is responding to a changed mechanical and chemical environment. And one of the things that changes that environment is the long-term use of medications that affect calcium regulation and vascular smooth muscle tone, including amlodipine. Here's what the research now suggests, and I want to be precise here because precision matters. A study published in the European Heart Journal found that among older adults on long-term calcium channel blockers, the rate of progression from mild aortic valve sclerosis to moderate or severe aortic stenosis, meaning meaningful valve narrowing that restricts blood flow, was measurably different compared to patients on other antihypertensive classes. The mechanism proposed involves the disruption of normal calcium signaling in the valve interstitial cells, the cells responsible for maintaining the valve's structural integrity. In plain language, amlodipine works in blood vessels by blocking calcium channels, but valve cells also depend on calcium signaling to repair and remodel themselves. When that signaling is disrupted over years, some valve cells lose their ability to regulate their own calcification properly. Instead of depositing calcium only when needed for structural repair, they begin depositing it in places and at rates that progressively stiffen the valve. This does not happen to everyone. Risk is significantly higher in people who are over 60, who already have any degree of valve calcification visible on imaging, who have other risk factors including elevated LDL cholesterol, chronic kidney disease or diabetes, and who have been on amlodipine for more than 3 years at doses of 5 milligrams or higher. Margaret had 4 of those 5 risk factors and nobody had ever explained the connection. Now let me tell you about Raymond. Raymond was 72, a former engineer from outside Nashville, the kind of man who read every label, kept a spreadsheet of his lab values, and arrived at every appointment with printed questions. He had been on amlodipine 10 milligrams daily for 9 years. His blood pressure was beautifully controlled. He felt, in his own words, perfectly fine. But Raymond had a habit that many detail-oriented people have. He noticed things, and what he noticed over the past several months was a very faint, very occasional awareness of his own heartbeat. Not a racing heart, not pain, just a subtle, pulsing sensation, particularly when lying on his left side at night. He mentioned it at 3 separate appointments, each time he was reassured. What Raymond was experiencing had a name, and it was not anxiety, which is what was written in his chart. What Raymond was experiencing were the early symptoms of mitral valve regurgitation, a condition where the mitral valve, which separates the left atrium from the left ventricle, begins to close less efficiently, allowing a small amount of blood to leak backward with each heartbeat. The mitral valve, like the aortic valve, is supported by a complex system of structures, including the annulus, a fibrous ring, and the chordae tendineae, tendon-like cords that anchor the valve leaflets to the papillary muscles in the ventricle wall. In people with long-term amlodipine use, the relaxation effect on the smooth muscle in and around these structures, particularly the papillary muscles, can gradually reduce the mechanical tension that keeps the mitral valve closing with precision. Think of it this way. Imagine the mitral valve as a pair of curtains held shut by cords attached to anchors in the floor. Amlodipine relaxes those anchors slightly. In a young heart with strong, elastic tissue, that slight relaxation is compensated for easily. But in an aging heart, where the annulus has already started to dilate slightly and the chordae have lost some of their youthful tension, that additional relaxation, sustained over years, creates the conditions for the valve leaflets to begin bowing backward slightly on each contraction, a condition called mitral valve prolapse, or in more advanced cases, for the valve to leak more noticeably. Raymond's echocardiogram, when finally ordered, revealed mild to moderate mitral regurgitation. He was told it was likely age-related. His amlodipine was not mentioned in that conversation. I am mentioning it now. This does not mean every senior on amlodipine will develop valve disease. The body has remarkable compensatory ability, and individual variation is enormous. But it does mean that if you are over 60, have been on amlodipine for several years, and have never had an echocardiogram or had one more than 3 years ago, you may be missing a picture that has changed significantly since the last time anyone looked. And this brings me to something that cardiologists are increasingly discussing, but that has not yet reached most general practitioners in a way that changes routine care. the concept of valve-directed monitoring in long-term antihypertensive therapy. The traditional model of blood pressure management focuses almost entirely on the number. Is the pressure controlled? Yes. Good. Continue. But the emerging model recognizes that the medication achieving that control is not pharmacologically neutral to every structure in the cardiovascular system. And the valves, sitting at the intersection of pressure gradients and calcium biology, are among the structures most worth watching. Let me tell you about Carol. Carol was 65, a retired nurse from outside Phoenix, which means she knew enough to be dangerous in the best possible sense. She had started amlodipine at 62 after a period of elevated readings that diet and exercise hadn't fully corrected. Her dose was 5 milligrams. She tolerated it well. No side effects beyond some mild ankle swelling that she treated with compression stockings and evening leg elevation. But Carol also knew something that most patients don't. She knew that ankle swelling caused by amlodipine, which is a well-documented side effect, occurs because amlodipine causes peripheral vasodilation, and fluid leaks out of the dilated capillaries into the surrounding tissue. It is not the same as the ankle swelling caused by heart failure. The mechanism is completely different. But Carol had begun to notice that her swelling, which had been manageable for 2 years, had recently changed character. It was higher up the leg, it was present in the morning, not just the evening, and it came with a breathlessness she hadn't had before. Carol did something that took courage and self-advocacy. She called her cardiologist directly, described the change in her symptoms precisely, and asked for an echocardiogram. She got one within 2 weeks. Her results showed early left ventricular diastolic dysfunction, meaning the left ventricle was having difficulty relaxing fully between beats and filling properly, combined with mild mitral annular calcification of the fibrous ring around the mitral valve. Her cardiologist transitioned her off amlodipine and onto a different antihypertensive class, a beta blocker combined with a low-dose ACE inhibitor. Her ankle swelling resolved within 3 weeks. Her breathlessness improved within 6. Her follow-up echo 8 months later showed the diastolic function had improved measurably. Carol saved herself because she knew the difference between amlodipine swelling and something has changed swelling. Most people don't know that difference. Now you do. Here is how to tell them apart. Amlodipine-related peripheral edema, the normal side effect, typically appears in the feet and lower ankles. It is worse at the end of the day after being upright. It improves overnight when the legs are elevated. It is roughly symmetric on both sides. It does not come with shortness of breath, fatigue, or reduced exercise tolerance. If your swelling matches that description, it is likely the expected pharmacological effect of the medication. But if your swelling has moved higher, appears in the morning after sleeping, is accompanied by any shortness of breath, has changed in character or timing from what it used to be, or if you notice that activities you could do 6 months ago now feel harder, those are not normal amlodipine side effects. Those are signals your heart is sending, and they deserve immediate evaluation, not reassurance. Now I want to talk about something that happens inside the heart walls themselves, not just the valves, because amlodipine's long-term effect on the myocardium, the actual muscle tissue of the heart, is a topic that receives almost no attention in routine care settings, but has become increasingly important in the research literature. Let me tell you about Gerald. Gerald was 74, a retired firefighter from outside Chicago, broad-shouldered, the kind of man who genuinely believed that feeling tired was just weakness, and that real men don't complain about the heart fluttering. He had been on amlodipine for 11 years. 11. His blood pressure was perfect on paper. But Gerald had developed something called left ventricular hypertrophy, which means the muscle wall of his main pumping chamber had thickened. This sounds counterintuitive because amlodipine is supposed to reduce the strain on the heart, and it does by lowering blood pressure. But here is the nuance that matters enormously for people over 60. Amlodipine's calcium channel blocking effect over many years can in certain patients promote a maladaptive hypertrophic response in the ventricular wall through mechanisms involving chronic changes in calcium-mediated cell signaling in cardiomyocytes, the actual heart muscle cells. What this means practically is that even with blood pressure well controlled on paper, the heart muscle itself may be undergoing structural changes that increase the risk of arrhythmia, reduce the heart's diastolic compliance, and set the stage for a type of heart failure called heart failure with preserved ejection fraction, or HFpEF, which is notoriously difficult to treat and disproportionately affects women over 65. Gerald's EKG at a routine appointment showed voltage criteria consistent with left ventricular hypertrophy. His cardiologist ordered an echo. The findings confirmed it. 11 years. Nobody had connected it to the medication until now. What Gerald needed, and what he eventually received, was a medication adjustment toward an ARB combined with a low-dose diuretic, specifically torsemide, which helped reduce the volume load on the thickened ventricle, combined with lifestyle modification focused on significantly reducing dietary sodium to under 1,500 milligrams daily. Within 14 months, his follow-up imaging showed partial regression of the hypertrophy. The heart, even at 74, responded. There is something profoundly important in that story. The heart is not a static organ. It remodels constantly. And that means the damage done by years of suboptimal medication matching can, in many cases, be at least partially reversed when the right changes are made early enough. Gerald's story is not a tragedy. It is a reminder that it is never too late to look more carefully. Now I need to address something that I know is in the back of many minds at this point in the conversation. You may be thinking, should I just stop taking amlodipine? And the answer to that question is an unambiguous, clear, and non-negotiable no. You should never stop amlodipine or any blood pressure medication on your own without direct medical supervision. The rebound effect from abrupt discontinuation of a calcium channel blocker can cause a rapid spike in blood pressure that is genuinely dangerous. In patients with coronary artery disease, stopping amlodipine abruptly can trigger angina or, in severe cases, a cardiac event. This is not a medication you simply decide to skip. What I am asking you to do is not stop. I am asking you to evaluate, question, monitor, and advocate. There is a profound difference between those two things. The medication you need to know about in this context is not amlodipine's replacement. There is no single universal replacement. What matters is the class. If you and your cardiologist determine that a change makes sense, the agents that current research suggests may have a more favorable long-term valve and myocardial profile for patients over 60 include ARBs such as losartan or valsartan, ACE inhibitors such as ramipril or lisinopril, and in certain cases, beta blockers such as metoprolol succinate or carvedilol. These decisions must be individualized. Your kidney function, heart rate, presence of diabetes, and many other factors determine which is most appropriate. This is a conversation to have, not a prescription to fill on your own. But if you have been on amlodipine, sold generically as amlodipine besylate, and under the brand Norvasc, available at virtually every pharmacy including CVS, Walgreens, and Walmart Pharmacy, for more than 3 years and you have never had an echocardiogram, that is the conversation to begin today. Let me tell you about one more person. Her name was Patricia. She was 69, a former bookkeeper from outside Seattle, meticulous about numbers in every area of her life except, somehow, her own medical records. She had been on amlodipine for 7 years and assumed that because her blood pressure was controlled and her annual physical found nothing alarming, she was fine. She felt fine. She truly did. Patricia's daughter, who happened to be a physician's assistant, came to visit for a week and noticed something Patricia had stopped noticing herself. Her mother was pausing on the stairs, not dramatically, just pausing, one hand on the rail, a breath, then continuing. Her daughter asked when that had started. Patricia couldn't remember. She said she guessed maybe a year ago, maybe longer. Her daughter ordered an urgent echocardiogram. Patricia's results showed moderate aortic stenosis. The valve area was meaningfully reduced. The gradient across the valve was elevated significantly. Her cardiologist estimated she was within 1 to 2 years of needing valve intervention if the progression continued at its current rate. Patricia had been symptomatic for at least a year. The pause on the stairs was exertional dyspnea. Her body had been signaling the problem, and she had adapted to it so gradually that she had normalized something that was anything but normal. This is the cruelest pattern in cardiovascular disease after 60. The body adapts, it compensates, it quietly adjusts to doing less, moving slower, resting more. And the person inside the body interprets every adaptation as just getting older because that is what we have been told to expect. That expectation, that quiet acceptance, is more dangerous than any medication side effect. Patricia went on to have a transcatheter aortic valve replacement, TAVR, performed at a major medical center. Her recovery was remarkable. She climbed stairs without pausing 4 months later. She cried when she told me she had not known for years how much she had been missing. What I want to leave you with is not a list of fears. I want to leave you with a framework for the conversation you need to have. If you are over 60 and you have been taking amlodipine for more than 3 years, the questions you should bring to your next appointment are these. When did I last have an echocardiogram? And does my current medication profile and duration of use warrant getting a new one? Do you see any evidence of valve changes, left ventricular hypertrophy, or diastolic dysfunction in my recent labs or EKG that would support closer imaging follow-up? Are there alternative antihypertensive strategies that would achieve similar blood pressure control with a more favorable long-term profile for valve and myocardial health at my age? And if I have ankle swelling, has it changed in character from what it used to be, and does it now warrant reassessment? These are not aggressive questions. They are not confrontational. They are the questions of someone who understands their own body well enough to be a partner in their own care. The body often changes before it speaks loudly. The heart often signals before it screams. The valve stiffens before it fails. The muscle thickens before it fails to fill. Every one of those early moments is a window where intervention is easier, recovery is more complete, and outcomes are dramatically better. Margaret opened that window. Raymond opened it. Carol opened it. Gerald opened it eventually. Patricia's daughter opened it for her. I am asking you to open it for yourself. If you are on amlodipine, if you are over 60, if you have been taking it faithfully for years and trusting that controlled blood pressure is the whole story, it is not the whole story. The whole story includes what has been happening inside the valves, the walls, and the chambers of the heart that pump blood to your brain, your legs, and your lungs every single second of every single day. That story deserves to be read while there is still time to write a better ending. Talk to your doctor, ask for the echo, know what is happening inside your chest. That knowledge is not scary. That knowledge is protective, and you deserve every protection that modern medicine can offer you, starting with the conversation nobody thought to start until now.